Welcome to our webinar about long COVID and new treatments and tests, which hopefully will make a difference to people's lives. My name is Dr. Ben Sinclair. I'm a doctor with a special interest in long COVID and ME/CFS. And I'd like to welcome you all to our webinar. I'd also like to welcome my co-host, Professor Andrew Shaw from Exeter University.
Evening.
Now, just to give you a rundown of what's going to be happening this evening. So we're in the UK, so we're talking evening time here. Now, we are going to look at new approaches to long COVID in terms of testing and in terms of treatments, particularly looking at monoclonal antibodies this evening. There's been some interesting developments in that area since our last webinar a few months ago. We're going to look at the clinical perspective here, and we're also going to look at case studies with live data coming from the Attomarker test, which Professor Shaw has created. And first off, we'd love to know who is joining us today. So we've got a poll coming up, and what we'd love to know is, are you a patient? Are you a carer? Are you maybe a healthcare professional? Or are you a researcher or a scientist? Or are you other? Now, we can't qualify the other, but we'd love you to just click on a button now, and let's see what we're getting in terms of people in the audience. That really helps us to understand. Okay, thank you. We're seeing some results coming through. Now, we've still got a very strong showing from patients. So welcome if you're a long COVID patient. Having been one myself, I know how hard that can be. So 77% of you joining us today are patients. We also have 8% carers. Caring for people with long COVID is a really important role. So please feel at home, and I really hope you can learn something today to help your loved ones and people you're caring for. We've got a few healthcare professionals joining us today, 4% of the audience, so welcome to you. Really great to have you with us, and please, all of you, feel free to answer questions in the Q&A section. We've got other 7%. Now, that could be other people who are joining us, maybe who are administrational or have an interest in this personally. And we have 4% who are researchers or scientists. So fantastic. So really great to have you all with us. It's really good to know what the audience is. That helps us to tailor our interest and our response towards what you may be looking for tonight. So what we'd love to do is just set the scene here. So first of all, this is being recorded, and we will be able to watch back after the webinar on the Dr. Finlay's Private Practice YouTube channel. And secondly, point of order, feel free to ask questions. We will then be notified of those questions by our team, and we're joined by Emily and Ellie, who are in the background here helping us to run the webinar. So thank you to you both for helping us to administrate this. And just to sort of go right back into the background here, just to remind ourselves what we're talking about. Long COVID in the post-pandemic era has become a significant problem. There are over 400 million people worldwide suffering from long COVID. And here in the UK, where Dr. Finlay's is based in London, we know there's over 2 million adults suffering from long COVID in the UK, and over 100,000 children affected. Now, our clinic's based in London, Birmingham and Leeds, and we're treating a lot of people from the UK and around the world through our multidisciplinary team. And part of the reason we got excited about testing was because we were going on this journey to understand how we might help people get better and to understand what the problems behind long COVID and possibly viral persistence were. Now, myself, I got long COVID after significant COVID infection, and with some real research, I managed to get better without knowing about the Attomarker test. But as I began to treat patients, I was looking for better ways to understand someone's immunity to COVID. And we know there's many different variants of COVID. So it does matter which variant you've been infected with, because that might still be hanging around somewhere in a part of your body and still giving you trouble. So I looked for ways to test for this. We were first of all interested in spike protein and antibodies, but I was introduced to Professor Andrew Shaw, who's more interested in the quality and quantity of antibody to the different variants, which gives us a great insight, I think, into understanding which variant might be affecting you and therefore which treatment might actually be helpful. So fast forward, we treated over 1,000 people for long COVID now, we're on the verge of hopefully offering monoclonal antibodies from our treatment centre in London. And I'd love to introduce you to Professor Andrew Shaw, who really is the mastermind behind this antibody test, to tell us a little bit more about the background to this test and why it might be significant in long COVID. So Andrew, thank you for coming. Can you introduce yourself as well?
Yes, of course, and thank you, Ben. So I'm at the University of Exeter, but I'm also director and founder of Attomarker. So we invented the technology at the university in a research grant, and it's now out available commercially. And critically, I think for long COVID patients, the test has now got a UKCA mark. We're looking at the full validation of it. So when the test results come out, it's done in a proper laboratory environment, which makes sure that the results are consistent. We've now tested nearly 500 patients. And we recently added the XEC variant onto the spectrum. So we're now looking at 15 variants with 15 antibody concentrations and also the antibody quality to each of those variants.
Fantastic.
So you want me to jump in with a bit of an immunology lecture?
Well, I was going to say, first off, actually, it'd be really helpful to know. Let's do another poll. Let's see if any of the audience members have actually already had an Attomarker test. And have they had a results consultation? So this is something we offered at the last webinar, and a number of people did sign up. We've been quite busy testing people and finding out their spectrum. So let's see, have anyone in the audience already had the Attomarker tests and results consultation? Okay, what have we got coming up here? So, okay, so 26%, that's 25 people out of a current 98 responders, have had a test already. So you'll be very interested in your own immune spectrum profile, and you'll probably understand a bit better the things we're about to talk about. Now, what I'd love to do then is really hand over to Professor Andrew, and what we want to do is understand the sort of the background to this in terms of the antibody science in a brief way, so that we understand, is it worth doing this test? What are the benefits of the test? And what treatments might then come out of it. So Andrew, over to you for a brief immunology overview. Thank you.
Yes, let's hope this doesn't become too much of a lecture for everyone, but I think we need to get on the same page for everything. So the test follows from the idea that when you get a COVID infection, the virus is in your body, it goes into your lungs, it goes into your bloodstream, it goes everywhere around your body and starts interacting with this ACE2 receptor, which is part of the part of the blood pressure regulatory system. If over a period of time you don't get rid of the infection in the first week, 10 days or so, then there may be some ongoing symptoms. And long COVID is this post-acute sequelae problem. It's sort of proposing the idea that the virus hangs around maybe in your lungs, in your digestive tract, in your heart, in your brain, a viral reservoir, a latent virus. It's not reproducing, at least not very often. It's triggering inflammation. It can cause all sorts of problems of dysfunction in your endothelium. So the question is then why? And what your immune system should do is attack it with cells, clear it out of the sick cells of your body, and then also go around your body mopping up any free virus that's hanging around with antibodies. So the test starts with looking at the antibody concentration you can see here to, in this spectrum, 14 variants, finishing at XP115. So this patient here made good concentration of antibodies actually following vaccination to all of the variants, which is the perfect response. That's what you'd hope. If you got infected, the antibody quantity would mean there's enough of it to get into all parts of your body and stick to the virus. But the sticking bit is key. This is the quality of the antibodies. And this antibody quality is sitting around 60%. So 60% of the antibodies are high quality, which means they stick to the virus, they stay stuck to it, and it gives you about 2 hours to clear the virus stuck with an antibody. And that's really important. All the body clearance mechanisms will then get rid of it. It will mop it up from your gut for your brains and your lungs. And so that's the way with which we clear it from the body naturally. We found that 65% of long COVID patients have antibody spectra that look like this. So they made some antibodies probably in response to the vaccine. When you get vaccinated or when you get an infection, you tend to target the spike protein and you make antibodies against specific targets. If the recipe that you target the recipe you make has a target that survives all variants, you get the universal responder. If it only targets some variants, then for these other parts of the spectrum, you're not going to get good antibodies, not going to get, in this case, good quantity of antibodies or good quality antibodies. So if this patient were to be infected, for example, with BA1, an Omicron variant, or later, the antibody quality is not good enough. It would not make antibodies that stuck to that, and so wouldn't clear from the body. I would suggest that's then a persistent virus, and then leads to the persistent virus hypothesis and all the symptoms that trigger from having long COVID. About 10% of people not only make a high concentration of antibodies and high quality antibodies, they make very large quantities of antibodies. They're hyperimmune. This is an autoimmune response. And we've measured with some patients those over time, and it just doesn't change. It doesn't drop. It doesn't go down as you get as you clear from the spectrum, clear from the infection as you'd expect. And so this is another process, and this means that you've started making antibodies to other proteins in your body, maybe in your heart body, maybe in your heart rather, or in your gut, and that's an autoimmune response, like arthritis, for example. So why is that happening? And from my point of view, I think this needs an early intervention. You need to look at why this is a problem and fix it. One of the patients we talked to recently is hyperimmune, and she then started off with all the symptoms from her long COVID, which once she started managing was much improved. She then started developing celiac disease and now alopecia, all of which could be autoimmune diseases. And I'm concerned that this person is now going to start collecting autoimmune problems. So that's the signature of autoimmune. Finally, 25% of patients look like they are normal, and we then need to hand that over to the clinician and say, I can't really tell from the antibody spectrum what's happening. So, so that's what the test does. That's the 3 groups, and that then becomes that's when the science then gets turned into medicine by you, Ben.
Okay, now I mean, it's really interesting seeing the differentiation of these 3 main groups. And clinically, what we've seen in practice is we do very much see people who have this sort of boom bust immune system, where they seem to have had a massive reaction to an initial COVID infection, or sometimes an injection, one of the vaccines, and they, I would probably say, would fit with your hyperimmune people, and we often find that those people have other challenges going on in terms of, as you say, things looking like MCAS or autoimmune type reactions. And it's interesting that you mentioned your patient who began to get more and more food sensitivities, or those sort of things. We see that very much as part of a sort of MCAS type reaction, where you've got this overproduction or over-aggressive immune system, but then you end up with fatigue as a result, because you can't continue reacting at that high level for long before you burn out the energy systems behind your immune system, and you result in, you know, a sort of a chronic fatigue process with high levels of stress hormones and the like, which then eventually actually causes low immunity, because someone then, you know, burns out and becomes much less responsive, less reactive, or able to respond to infection. So I definitely relate to that. And the 25% who have what's a normal spectrum but still have long COVID, I would suggest probably have other either pathogenic or other processes that are not tested here. So, for example, they may have a bacterial problem like Lyme disease or Bartonellosis, or another virus like Epstein-Barr, or indeed have set off some sort of mitochondrial problem or allergic reaction, which leads them to still have produced enough antibodies, but they are still having some metabolic dysfunction causing fatigue and the cognitive problems that we see post-COVID, or they have complications from the spike protein that has been produced in their blood vessels that then impacts their organs, in spite of having produced, you know, appropriate levels of antibody. And I think the really interesting group are the ones who just produce this sort of the 65% who produce a reasonable response to some of the strains, but then actually really aren't producing, you know, a good quality or quantity of antibody. And we see associations in that group of hypermobility. Certainly, they seem to be a group who are predisposed to increased neurodifference, and there may be an association there with hypermobility and hypoimmunity. So they're not producing an appropriate immune response to an infection and become immune suppressed. And I think those people often have had problems in early childhood. They've often had antibiotics in early childhood, recurrent infections like ear, nose, and throat infections in childhood, or they've begun to have hypermobility problems at an early age that often you can spot when you look at the history. So there are some clear sort of phenotypes coming out around the test results, which are quite interesting from our studies of these groups. Now, I think what's exciting about the testing is, obviously, we know that COVID spike protein can bind to ACE receptors, begin to cause problems, and you can try to block that. But ultimately, what we want is something to mop up that COVID spike protein, and that means a quality antibody response. So for me, the quality of the antibody is the bit that's lacking that we didn't have before. And Andrew, obviously, we used to measure antibody responses to check that you'd had an appropriate antibody response to, let's say, a COVID vaccine or an infection, to test whether someone was immune. What we never knew was whether it was a high quality response or not, and that's the bit that was lacking. And what we often found was that people who had what looked like reasonable amounts of antibody didn't have quality in particular gaps, and sometimes that matched up with the variant that they were infected with, and that was the sort of the trigger of their long COVID, that particular variant. That leads me to ask you whether you have any sort of, I guess, particular cases whereby you see a particular variant identified with the onset of a long COVID, and whether you could sort of show us some of the spectrums that we've looked at recently, in which we've also done interventions like monoclonal antibodies, because monoclonal antibodies are essentially a synthetic antibody that's supposed to have a good fit for the variant you're trying to treat. And they may make the difference, mopping up the spike protein produced and therefore protect you from COVID and deal with viral persistence. So I'd love to know more about some other cases, Andrew, you can show us, and different spectrums and what those cases demonstrate as a sort of learning lesson, because we're actually now getting these sort of phenotypes coming out in practice.
I like learning lesson. I think I've had some really good, interesting scientific ideas, and suddenly when they get translated into medicine, then something in the processes of the body we didn't quite understand to start with, and they're not in my simple scientific analysis. So let's look at a few. This is a patient who is making really quite high antibody levels here in concentration. This is, I would definitely say, they're hyperimmune. But if you look at the back end of the antibody spectrum here towards the later variants in XEC, the antibody quality is not very good. And at 25%, I would have said there's a risk here of this patient now not being able to clear the virus. We think the threshold is around 37% for long COVID patients. So if you're above 37%, it will stick for long enough, that will go and make the clearance process work. But look, this is a really busy immune system making lots of antibodies, very high concentration antibodies. But for the rest of the spectrum, they're not very useful at producing this clearance effect. So this is almost hyperimmune for early variants and then immunocompromised for the later variants. It's a really interesting idea. No reason why I shouldn't mix up my simple classes, but I think that's true. This one here is from our recent US cohort. This person here is making extraordinarily large numbers of antibodies. This is one of the largest antibody concentrations I've seen in a patient naturally. Now, there's a lot of discussion about whether this is vaccine injury, but this immune system here is completely over responding to the production of Wuhan Alpha and Delta variants. And it's going to be distracted, busy, saturated. And so things, as you mentioned before, like resurgent Lyme, EBV, I think they become the problem. So knowing that you're in this subgroup, this has got to be switched off. And we can talk about ways of switching it off at some point, even filtering it out, such as apheresis. But again, some of the quality of the antibodies at the back end of the spectrum here, not as good as I'd like them to be. But what if we could take an antibody spectrum like this one here, where there are obviously gaps? When you get sick, you inevitably make your own variant. You must do. That's how variants are made, by a particular patient inventing something. So it doesn't follow that you got sick just with BA1, but something close to BA1. And wouldn't it be good then if you could then give an antibody like Pemgarda? Now, this is hot off the lab. It's passed all the quality control tests and everything from the lab, otherwise they wouldn't release it. but this is a before and after PEMGARDA patient, and it contains some surprises. I have to say, this is not exactly what I think was going to happen. So first up, I wasn't talking to the clinician that had treated them with PEMGARDA. So when their antibody level came up here for alpha at 176 milligrams per liter, I would have been thinking, scientifically, that's quite a high concentration. Should they be getting PEMGARDA? Is there a risk of autoimmune diseases? Maybe. But the antibody levels here and the quality towards the back of her spectrum suggested that maybe the virus would be persisting. Bad quality, not sticking, not clearing. Then as of about a week after this top spectrum was recorded, the person then took a PEMGARDA infusion from a clinician in the US. So now you can see that the antibody concentration has gone up by what, factor of 8 or something. This is really quite close to the safety limit for infused antibodies, which is around 1200 milligrams per liter. So I am quite shocked by that result. It also looks like all these other antibody levels here towards the back part of the spectrum are much, much lower. So the drug itself responds to these variants. So the synthetic antibody works against these variants. And it looks like, and I don't know this is true, but just first thinking about it, natural antibody production has been switched off and been replaced entirely by the synthetic antibody. But she's making the PEMGARDA antibody is binding to XBB1 rather, and the Omicron variants, and her long COVID here started with an Omicron variant. So very important sign medically to work out when her long COVID symptoms started and what the circulating variant was at the time, subject to me saying that you might make your own variant. But if it were true that this patient here had low quality antibodies here sitting at around 30%, put the PEMGARDA in, giving you high quality antibodies sitting around 50%, then that would result in this patient getting better. And she has.
Did she get better?
Yeah, she has got better.
And what got better, Andrew?
So this was bedbound and a really poor long COVID experience to recently climbing the steps of Montmartre Cathedral in Paris. So she would probably claim that her long COVID has pretty much gone. And looking at it, it's got to be this antibody quality, or maybe this antibody quality, that's done the clearing process. So it was quite lucky. And there's not much evidence here for me that the antibody concentration for the Omicron variants was particularly low. The quality is quite low, and going from what, 28, 30 up to 50, maybe that was the difference. Maybe this concentration, it's really small here because this is such a large scale. The number down here is about 16. That combination together, maybe that was enough. But for me, the PEMGARDA is a very targeted antibody. It's going to work against some variants. It won't work for many people. And you'll only know if we are able to look at the antibody spectrum. So unless you know you've made bad quality antibodies to these variants and PEMGARDA can help you, then there's a good chance it won't work. And I think that now reflects on all of the studies out there. Sotrovimab, for example, which is the one that you're hoping to get, Ben, is pan-variant. So it should produce good quality antibodies across this variant spectrum. It doesn't work for Nimbus, the latest circulating variant. There's a mutation on that means it doesn't work. So you should get really good quality synthetic antibodies across the spectrum and high quality. So Sotrovimab could be better than PEMGARDA. So this was for me, was a very an exciting development, but proves the antibody hypothesis. But it wasn't quite what I was expecting to see when the data arrived this afternoon.
Now, data is never exactly perfect, is it? And we've got to bear in mind this is one patient and n equals one, study. However, I think what is interesting is, though, it shows that perhaps increasing the concentration of her Omicron variant that increased from by 20%, by 20, sorry, actually might have made the difference if that was the one that she needed to clear in terms of quality. So for me, what it highlights is the quality of the antibody and the variant really does matter, because this patient went from being very unwell and limited function to a greater function. Now, we don't know what's going to happen with this almost sort of overproduction of the early variant antibodies in time that might come back to bite us. And I think it's really important to highlight that I probably wouldn't give monoclonals to someone who had one of these sort of hyperimmune presentations without trying to reduce the hyperimmunity first, because actually you may well, as you say, garner more almost like autoimmune or hyperimmune problems later as the immune system sort of goes into overdrive. But she did get better, and this is a short, very rapid change in her spectrum. So it'd be very interesting, Andrew, to actually repeat this spectrum in a few months' time and see. I think the other thing that strikes me, Andrew, is also I guess the question of the is it covering the latest variants? It depends on whether you need to cover for latest variants or you're more interested in trying to treat previous variants. So that the license for these medicines primarily is to protect you from the current circulating variants. But actually, what we're also very interested in is, can it solve the problem of the ones you've already got? So it might not treat you against the current ones, but it might treat the ones you're already holding on to.
So that worries me quite a lot, actually. I think Sotrovimab should work well for all current long COVID infections, unless you've got it in the last 3 months or so. And if your persistent variant is Wuhan or your persistent variant is Alpha or Delta, then it's going to work well. If it's Omicron, it's going to work well. So what I don't want AstraZeneca to say is that Sotrovimab is being withdrawn because it doesn't work against the current circulating variant, when we know there are 400 million people out there for which this latent variant might be removed really quickly. So I think one of my concerns is making sure we have enough antibody spectra so that we can say to AstraZeneca, there is a large body of people out there for whom we already know that Sotrovimab would be useful.
Yeah, very good. Now we have two other interesting cases that highlight different spectra. Andrew, would you be able to just talk us through those cases in which monoclonals have also been used, or Novavax has been used? And there's a question asking about treatment with Novavax from Marcia and Della. So let's get the answer here on the Novavax intervention.
So Novavax, I'm very aware that long COVID patients think that vaccine injury is a problem. So it's very important to me that Novavax is a protein vaccine. It's a very traditional vaccine that somebody like Edward Jenner himself would have understood. It goes into your arm on an adjuvant. It stays in your arm as a protein. There's no message moving around. There's no messenger RNA appearing in your gut or your lungs. So it's, I think, much safer. I've had it twice myself. And this patient here is another example of a long COVID patient with gaps in their spectrum. And you can see that if their persistent variant was an Omicron spectrum, an Omicron variant, or JN1, for example, that would be a problem. It would simply just not be there. The antibody concentration is quite low as well. The antibody would not be there with the quality and the quantity to clear that. So they then were treated by a clinic in London to get Novavax. Novavax should be available again in the autumn. And this is your body making new antibodies. So effectively, the Novavax triggers a new recipe. It says, I haven't seen this spike protein before. I've got to invent new antibodies to clear it. And this patient, as you can see, got double the antibody concentration for the early variants, which was in part working before. But now these varying concentrations are rising, especially some of the later ones. But look at the quality. The quality is doubled in the early variants. And now the antibody spectrum is not just filled, but repaired. So the difference between the Pemgarda one is over time, it's going to fall and the antibody levels will return to, the spectrum will go back to this spectrum, for example. And that means they would be at risk of getting COVID and potentially long COVID again. Whereas this patient, following the vaccination, has changed their recipe for antibodies. They've repaired their spectrum, and they're no longer, I think, at risk of getting COVID again, unless the variant is really very, very different. So this is almost a better permanent state. This person lost her symptoms within a month. They got 3 jabs of the vaccine a month apart, and this is what happened after the first month. So this is a really interesting result, and I think a permanent fix. So given the caveat of vaccine injury and anxiety around vaccines, this is arguably a better solution than getting monoclonals. So one monoclonal study that we have tried is here, which is an early study. So this patient here had very low quality antibodies for the initial variant, the Wuhan variant, and they received Evusheld. And Evusheld was one of the early antibodies, and the early relative to Sotrovimab. So Evusheld is also AstraZeneca, but it only worked against the low early variants and doesn't work at all against the later variants. When we gave Evusheld, when the Evusheld was given, the antibody quality improved for Wuhan, and the patient started getting better. They would argue they're completely better now, but the journey was much longer. It wasn't a 1 month. It was a very long journey. They had resurgent EBV, they had resurgent herpes, they had resurgent Lyme, all sorts of problems. Some of which was cleared up by apheresis, which we can talk about later on. But over time, their antibody levels rose. They went on holiday to Greece for the first time in a while, so the antibody effects were working. But the result from this experiment, I think, critically, was we measured the fingerprint of Evusheld in the serum, and then we measured the fingerprint of Evusheld in the CSF. And it got across the blood-brain barrier. About 0.5% of what was in the serum got into the brain. And that is what proved the winner for the brain fog.
Interesting.
So that, for me, means that many of the symptoms that are present are going to be addressed by the monoclonals. If it overlaps with the spectrum of the monoclonal, like this is the Evusheld one, because it worked well for Wuhan, it overlapped well, and I think it might then perfuse around the body and clear it. That's the hypothesis we want to test. We have to now treat the right patients with the right monoclonal.
Andrew, on that question of the blood-brain barrier, do we have any research understanding of whether the other monoclonals like Pemgarda or Sotrovimab do get across the blood-brain barrier in significant concentrations?
No. So the reason this worked is because the fingerprint in the blood was now seen in as the same fingerprint in the CSF.
Right.
And that is very rarely done and very difficult to do if you're not looking at the spectrum. And so we could take the Pemgarda spectrum now. We see there's some early variant signatures here and some of these quality signatures, and then look to see if it got through to the CSF. My hope now is that, having shown that Evusheld crosses the blood-brain barrier, the antibodies are not very different, and the mechanism that's allowing it to being transported will work for the other variants. We'll find that out though, because they are synthetic antibodies, and some of the regions in which they have been changed may stop that blood-brain barrier transfer. But we can look at the signature either side, the fingerprint either side of the blood-brain barrier, and I don't think anybody else can do that.
And I think this is the highlight of why some of these trials using MABs have been ineffective, because they weren't distinguishing which variant they were treating. And so quite obviously, if you've got a variant that is an early variant, but you give it a late variant MAB, it's not going to help. If you've got a late variant and you give an early variant MAB, it's not going to help. I think you do have a slide about a patient who got Evusheld but didn't get better because we had that the wrong way round as well. Is that right?
I haven't collected that data yet, but you saw this patient.
I did, yeah.
We provided you with the spectrum, and yes, they had, from the clinical symptoms, long COVID associated with Omicron, and Evusheld just doesn't work against that.
That's right.
So that's a negative. We're going to put this together in a paper, which we'll co-author, where all of these signatures, including that very important negative results, will be contributed. You've also treated somebody with Sotrovimab.
Yes. So we had a patient who was very poorly with multiple co-infections, but still demonstrating some significant problems associated with COVID. And the spectrum essentially indicated that the patient might benefit from MABs. At that point, we managed to get hold of Sotrovimab, and the patient had 3 doses of Sotrovimab over a number of months. And very interestingly, on the second dose, experienced, again, very similar to your PEMGARDA patient, a significant improvement with physical function, ranging from, virtually sort of room-bound, bed-bound, right up to being able to go out of the house, step count, tripling. So it seems to be that when we get the right variant and we hit it right, we do get a significant response. Now, interestingly enough, that patient also had multiple other co-infections, Epstein-Barr, Lyme, and the like. And so, unfortunately, there was a ceiling on the recovery because we sorted out the long COVID bit from a COVID persistence point of view, but then we had to deal with the other co-infections as well because the patient was already heavily immune suppressed. So I think what's important is that we target the right intervention of the right patient. And I think there's a question that in the responses here about commenting on other MAB trials, such as UCSF's AER-002 trial, which didn't have any effect, and the Temelimab trial in Geneva, which showed no effect. And I think the answer to those is it's very likely that in those trials, because they weren't aware of who the cohort were that were being treated, they may have been the wrong MABs for those people. Whereas with this sort of test, we're hoping to really understand who we're treating with what, and also reduce the risk of giving the wrong treatment to someone who's hyperimmune or the variant that isn't going to be effective. So I think that really does help.
So I think you've hit the nail on the head. First of all, the translation of the science into medicine with all the other symptoms and the busy immune system allowing resurgence. I think all that medicine is not predicted by my science, but the science points towards whether the immune system at least can respond to COVID. I agree that all of the other studies, if they haven't pre-selected the cohort into this 3 groups, and the MAB's really only going to treat this group, and then we've got the spectrum of the MAB, the targeting of the MAB itself. So I think the PEMGARDA trial is going to be very difficult to show whether it worked for a number of reasons. One, it will work well against only certain variants, and if the long COVID doesn't coincide with that variant, that's going to miss the target, simply miss the target. The other thing is, what's the outcome of the trial? As you've talked about what recovery looks like, I've mentioned recovery is quite complex. If you're looking at recovery symptoms as your output, then it might take 2-3 years to recover. You may be experiencing symptoms associated with something else and not the COVID. So if the outcome of the trial is getting better, that's going to be hard to measure. If the outcome of the trial is fixing your antibody spectrum before and after, we've done that, something changed physically. I'm also interested in subtypes of antibodies like IgG4. You make that if you're persistently exposed to things like intolerances in food, for example. If you're becoming intolerant to the spike protein, but we take that away because it's cleared, then the IgG4 levels might fall. And then you've got a companion. I treated somebody, it was high, and now it's low. I like that idea. So I can see the chemistry changing. I don't think it follows naturally that somebody who's been struggling for 5 years now with COVID, persistent COVID, is going to get better in a month. They may get better in 5 years. And I think that the trials are fairly simplistic in design around, do they get better? So they can miss the target for sure. They could putting people that are hyperimmune into the study. That's not going to work. I don't think 25% are going to respond either. So 35% are not going to respond at all. 10% I think are at risk of something nasty happening, because as we've seen with the PEMGARDA study here, this is a big number. And imagine if I give this 800 milligram per liter natural, maybe let's call them vaccine injured, more antibodies, what does that do? That's, if you put this up by a factor of 8, that's a real problem. I don't think they should be, until you've got that under control, doing anything. But 65% might work, but if the MAB doesn't work against the variant, it's just going to miss the target. So what's the outcome of the trial going to be? It didn't work. It's not going to be effective.
Okay, so I think as a bit of a segue to the next section, we've got lots of questions coming up to answer, which really help illustrate this. I'd like to do another poll. So, having heard about this sort of test and the results, now majority of our audience today are patients or carers. So, would you book an Attomarker test consultation, having understood, hopefully, some of the science behind this and what it tells you. So let's see, would you book an Attomarker test having heard this? And let's see what the results are. Okay, so again, so interesting. So 67% of the audience would consider booking an Attomarker test. So that's really interesting. 9% say no, and the maybes actually are, on the fence. And obviously, we have to think about the benefits of where we're going to allocate this. This is a private, it's a test, it's experimental. So so people aren't sure whether it's worth their bang for their buck at this stage. So I think we should also talk about just some of the questions that are coming up, which might illustrate some more of the benefits of the test. So let's have a look at some questions. Now, one really quick one I can knock off. Andrew, the test used to be a finger prick test, which is quite painful because you've got to jab yourself and fill a little bottle with blood. And I messed it up the first time, had to repeat it. Tell me about the new device that you've got doing the test.
Okay, so I too am not very good. A couple of observations. When I do it for myself, it looks like a crime scene in my kitchen. It's just crazy. I am not very, and it hurt. If you get a nerve and
Painful. It really hurts, doesn't it?
And some people just don't believe very well at all. We had somebody who was a plumber coming for a test recently. His skin was like leather, and his fingers just didn't. Okay. But what we have now done is introduce this Tasso device. So you can see it here on the arm. The use is you put a warm patch on your arm for a while, and it brings the blood to the surface of your arm. You put the Tasso device on, it just sticks on the skin. You push the red button, and there's a little vacuum generated, and it sucks the blood out of your arm into the little tube you can see at the bottom, and it produces some really easy blood draw. Very, very easy. I was walking around the lab taking a phone call while I was being bled. There was no blood anywhere, and
fantastic.
I think it's a game changer. So I think we're running the evaluation study now, and we will be getting ready to deploy that for all of the clinics. So much easier for me to ship it. With the EU Apheresis Centre down in Cyprus is a good opportunity for us. RCH are bringing in some apheresis. We should talk about that as well. But in America, the second wave of American patients will definitely collect with the Tasso device.
Okay, great. Thank you for clearing that up. So it should be a bit easier to get the blood test done, a bit more palatable, and hopefully that shouldn't restrict people from getting it. I mean, the good news is it's postal, so you haven't got to go to a lab or go to a clinic to get it. So you can do it from the safety of your own home, which makes it accessible. And at £325 for a test plus consultation, compared with other tests in this ballpark, I think that's actually quite a reasonable cost, albeit, yes, in the UK and worldwide, you do have to pay for that yourself. In the UK, we hope that various things will be provided by the NHS, but this is cutting edge, so as yet has not been adopted. But we do hope that the government of the UK will understand the benefits of this sort of testing, because there are hundreds of thousands of people who are ill, off work and on benefits, claiming Social Security at the moment because they can't work. And we know that they would love to get back to work. And we honestly think that this may well be really instrumental in helping those people to get back to work if we identify who's suitable to treat. And they might need a Novavax, they might need a MAB, or they might need antivirals. But actually, we stand a good chance of identifying the right people to treat with the right therapy if we know what their spectrum's doing. So I hope that's going to be helpful. Now let's just have a look back. Someone has asked, what would the antibody spectrum look like if you had a reaction to a vaccine? So what if your vaccine had created this? Andrew, do you have anyone who has a sort of in your cohort that was the test group, were they a mixture of vaccinated and unvaccinated people? Were they all vaccinated that we're comparing to?
So the American cohort contains a number of people that are vaccine injured. So they have received the vaccine and immediately, as a result of that, started developing acute symptoms, and that then became chronic into their long COVID. So the vaccine injured group are probably, and this is difficult to prove yet, but are probably the hyperimmune group. I think the mechanism for me here is the vaccine was a messenger RNA, and the message had left your arm and then found a heart muscle or an ovary muscle, an ovary rather, and we know that the message has been found around the body. So we know the message was escaping. If you started making spike proteins in a heart muscle, then your body attacks the spike protein in that heart muscle. It might attack the other proteins in the heart muscle, and suddenly you have the autoimmune response. So that patient I showed with the 800 milligrams per liter, very extreme response. I think that's a vaccine injured patient. Now, all I can say is scientifically they've got a hyperimmune response, a very hyperimmune response. To prove the vaccine actually did that is very hard. But if you had a patient who was vaccine injured, they had, you could show that the spike protein was present in a biopsy, for example, then we might even be able to go and find out what other proteins the antibodies have been raised against. It's a long journey, but I think the hyperimmune response is possibly it. So I think if you're in that group, that's the one that they're the group that need to be off to see you quickly to get treated to find out whether suppression works. What about apheresis? Do you like the idea of apheresis?
It's a really good question. I mean, the question is, what do you do with this hyperimmune group? And I think, as I said before, there seem to be some associations that predict the likelihood of being in that group with previous hyperimmunity, and also family history of things like autoimmune conditions, thyroiditis, Crohn's, ulcerative colitis, arthritis, celiac disease. These things tend to crop up in the family members of those hyperimmune people. I think immunopheresis holds promise because we may be able to filter out some of this autoimmune overproduction of proteins, and then have a chance to sort of hopefully reset, get in with some calming strategies, medications, which might not be tolerated if you hadn't done immunopheresis. Although, again, the long-term studies don't really exist about the risks and benefits of immunopheresis. But in the short term, we're not talking about pulling out just the spike protein. We're talking about pulling out the immune proteins associated with the hyperimmunity. And I think that might confer a chance to reset the immune system and have a more appropriate immune response. I guess the other thing is that people are using rapamycin to help downregulate immune system responses, and that also may hold promise. Again, we need to understand the risk benefit before we leap into sort of immune therapy like rapamycin, because not everyone will respond well. So again, we want to make sure that we're choosing the right people for that sort of intervention. And I think, and we have to always consider the risk benefit with any medicine we use.
Yeah. Have you tried steroidal?
So interesting enough, we have tried some steroids. So we're thinking of things like hydrocortisone, prednisolone, dexamethasone taken orally. So the systemic steroids. I think when we were doing that, that was earlier on in the long COVID sort of story, and we didn't have the differentiation that we have now with the Attomarker test. So I'd probably like to go back and revisit trialing that. What I've found is that steroids are a bit of a double-edged sword. They can downregulate hyperimmunity, but then you can end up immune suppressed and allowing other bacterial pathogens to overgrow, and then you end up with another problem, or you a danger of pushing people into illnesses like sort of adrenal problems as well. So it's a fine knife edge to travel on with steroids, and the challenge is getting off them. Do you then end up bouncing back, and the complications of steroids in terms of risks of bone thinning or risks of gastric ulceration are not insignificant to think about. So we have to judiciously use them as well.
I think for me, it's very interesting now to compare any interventions against the antibody spectrum. So I know for somebody, example, somebody's on the remdesivir trial, that's an antiviral, and they're hyperimmune. I just don't think that should have any effect on them at all, would be my prediction, because the hyperimmunity, their long COVID symptoms, is not triggered by persistent virus, and indeed not active virus. Some people in that study and that trial will get better because they will have latent virus. If it's active, it will be taken out by the remdesivir. If it really is not active, then it will still be there, and later on it's going to come back. So it could be fairly short-lived.
Yeah. Now, people are asking questions here about whether we might be considering using antivirals to get viral load down before we then use monoclonal. In the case of the Sotrovimab, we did actually use a sort of a preemptive strike with antivirals and then give the monoclonal. And that whether, well, we don't know, it was a small trial on one person. We don't know whether that was a significant intervention, but the second dose, which did coincide with using the antivirals, may have made the difference of the potency of that second dose. We'd have to do more to see if that was a true effect coming out, I think.
So my scientific logic here is if we're disturbing the viral reservoirs, if they're near ACE2 receptors, it will become active. If it is active, then that's potentially inflammatory, that's potentially infection. So why not have Paxlovid or something that's well targeted against the virus?
It does make sense.
On top of, yeah. So I think it's scientific, logical. You're absolutely right that we need to turn the science into medicine. And what worries me is even now, if we run a few interventions with MABs, there aren't interventional protocols for the other types of patient, and that's
hard. And I guess part of the challenge for me as a clinician is we're dealing with the whole spectrum of long COVID and other chronically fatigued patients. So it's not just viral persistence, it's Lyme, it's Epstein-Barr, it's mitochondrial problems, it's a psychological driver of immune suppression through high cortisol, it's sleep disorders and everything that comes with, and spike protein causing vascular endotheliitis. So there's all these things in the mix, and filtering them out, we're now getting a little bit more specific. Circling back to the sort of the vaccine injured group, I would say as well, some of my patients who thought they were vaccine injured, we've actually now proven were not vaccine injured, but had a vaccine and then had what we suspect was a lot of cytokine release and an immune sort of overreaction, but then a significant immune suppression latterly, which then allowed bacterial infections such as Lyme to activate or reactivate in their case. And when we tested them, they didn't have any evidence of ongoing spike protein production, which is one of the concerns with vaccine injury. Are you continuing to produce spike protein from an mRNA vaccine? And in some of these patients, actually, we discovered they weren't producing spike protein. They didn't have measurable levels of spike protein in their bloodstream. It wasn't being presented on their monocytes, and it wasn't in the exosomes. And so, and they didn't have mRNA in the exosomes either. And so we then treated them for the bacterial infection, and they actually improved without doing anything with the spike protein, because that wasn't the problem. So I think that sort of vaccine injured group, we shouldn't assume it's only COVID related, but there is definitely a hyperimmune group within that vaccine injured group who, if you give a Novavax to, we know that if you give Novavax to some people, there was a group of doctors who all took Novavax. Some of them got better, some of them got worse, some of them it made no difference. If only we'd done their spectrum, we would have understood before which ones would have benefited and why. So I think that does help us. There's a quick question here saying, what does it mean if you have 100% high quality antibodies? Does this mean autoimmune issues? Essentially, no. If you've got 100% at the appropriate level, you're not autoimmune, you're appropriately producing high quality antibodies. It's the figures on the left-hand side of the chart, to be clear, are not a percentage, they're a measure of antibodies in the bloodstream. So so if you've got an antibody level of about 8, I think on your scale, Andrew, it's about right.
Yeah. Yes.
So that'd be right. Yeah, that'd be okay.
If all of your antibodies are high quality, we measure the quality by looking at the antibodies that survive at higher pH, lower pHs. It means those antibodies would still work in parts of the body like the mucosal membranes where the pH is different from your blood. And that's what the quality means. And it correlates well with how well they stick. So 100%, we've seen that in quite a few patients, really good quality antibodies. They just make antibodies that are going to stick. It's a good response.
Yeah, okay, good. Let's look at another question here. We've got a question about the spike protein. Have you had trouble with people clearing spike protein from their blood vessels, and how you treat this? Is it not classed as a viral persistence? No, you're right, it's not viral persistence, but you may have spike protein persistence, and it might be continuing to be presented by your monocytes to your system, and therefore then produce an immune reaction. So we want to break down COVID spike protein, and there's various ways that you can try to do that. Things like nattokinase and augmented NAC or NAC can help theoretically, and do seem to help. There also seems to be a benefit from statins in terms of stabilizing the artery and blood vessel walls, which seems to have a beneficial effect in this sort of presentation. And it may be that actually medicines like Maraviroc did help us to kill off cells that were living too long and continued to hold on to or sort of present spike protein. So the question earlier up was, are we still treating people with Maraviroc and a statin? The answer is we're not really doing Maraviroc because we didn't see it working effectively, but we are still using statins judiciously, and atorvastatin 10 milligrams or pravastatin 10 milligrams seems to confer a benefit for blood vessels. Also, they seem to be mast cell stabilizing as well, which is quite an advantage for people who are too reactive and actually can calm down some of the most hyperimmune people, interesting enough. So statins seem to help for the hyperimmune group as well. And we don't really know why. And we're also seeing people benefiting from resveratrol, which is an extract of red grape skins, and probably why people who drink red wine have less heart attacks. But resveratrol actually calms down blood vessels a bit like a statin, although it doesn't have that sort of mast cell stabilizing property. So there are a number of things we can do to get rid of spike. The other thing you can do is fast if it's safe to do so. Fasting for 2 to 3 days can actually help you to apoptose or kill off cells that are still holding on to spike protein and allow that to leave the body.
Do you think it's residual spike from the infection, or do you think spike is being made somewhere?
Great question. I think if you've had an mRNA vaccine, you might still be producing spike yourself. I think if you've got viral persistence, you might still have spike being produced by a low-grade background viral replication process. Or I think if you've had COVID in the last 6 months, that spike could still be circulating and being presented by your cells. Don't forget, it binds to the ACE receptors, it binds to the nicotine receptors. And what we found is that we've also used ACE inhibitors like telmisartan to try and bump off that spike, and that also seems to help. There was a trial done in pigs where telmisartan actually protected them from getting infected with COVID. So if we think laterally with that, we may well be able to protect our ACE receptors from the spike effect by blocking the ACE receptors using ACE inhibitors. So there's other ways to do that, and the nicotine receptors, you can bump off spike from them and then benefit yourself from trying to kind of mop up the spike as well. So there may be some ways to get rid of spike. Ideally, you want to avoid reinfection. That's a really important point, and I don't think people are taking reinfection seriously enough because it's still circulating. Andrew is demonstrating new variants on the test all the time. So it's a significant challenge. Let's just see what else we've got here. Okay, so we've got some great questions coming here. It's 35 questions. I hope we can cover them. It says, what if Sotrovimab becomes available in the UK? Will you prescribe antivirals? We've talked about that, but actually, more importantly, people are very concerned that will Sotrovimab actually be available in the UK? Part of the challenge is that actually, I think because things haven't been working out quite so well with other MAB trials, the drug companies are thinking they're going to withdraw MABs. And part of our role here is to work out how to appropriately use them and demonstrate the benefit. Andrew and I will be writing up our findings in a paper which we'll publish, and we hope that then that pilot study will go on to a larger study which would convince people of the benefits of using MABs in the appropriate patients. So we're really hoping that we don't lose these medicines. Now, we've also applied to the MRHA for a special license to enable us to be able to give these medicines. Now, it's on a named patient basis, so this is not a mass treatment program, but we really would hope that eventually people like the NHS or big health organizations, if they can see the benefits proven in the study, might adopt this, and that might roll that out to many hundreds of thousands of people around the world who might benefit from appropriate treatment with the right monoclonal. And hopefully they might create more monoclonals for the variants that we're getting now, Andrew. I don't know if you know about any more ones in the pipeline.
So I know AstraZeneca are looking at the future for Sotrovimab because it has now walked into this mutation, which means it doesn't work against the Nimbus variant. I think there's a danger of them withdrawing it. It's been approved for use in the EU. It's under review by the MHRA in the UK, but the use is against acute infection. And if you're getting a Nimbus acute infection, it's not going to work. So there's a problem with Sotrovimab. I think similarly for Pembrigada, I haven't heard of any monoclonals that work against these later variants completely.
And it's difficult because they may not be creating them, I guess, fast enough.
Yes. and even Novavax has a risk of not being able to keep up with everything. But I think that Sipavibart will be useful against lots of long persistent virus from long COVID patients. We just need to prove it quickly, and then maybe run the trial formally so that AstraZeneca can sponsor it and we can get it then available.
Now, another question here from Joseph Corrigan. For patients with an insufficient antibody response shown by Attomarker test who've received one Sipavibart dose, how long should they wait to retest the antibody response? And how long should they wait to have a second dose of Sipavibart? What's your thoughts on that theory, Andrew?
So Sipavibart has a half-life of about 80 days, which means whatever the initial concentration will rise coming out of your leg, and it will reach some sort of maximum level after the first dose. And then after 80 days after that, it will have halved. So I think a second shot somewhere between 1 month and 2 months means the antibody level will then rise further. And for me, that helps perfusion. That means that you'll have a higher concentration in your blood. That will help it get around the body, into the gut, into the blood-brain barrier. So scientifically, 2 shots, maybe 3 shots, looking to see some benefit arriving at least during the second shot before continuing. And again, that's a medical decision about whether the third shot's valuable or not.
Okay, great question. Thank you. Someone's asked, if I had mononucleosis as a teen and a herpes virus in my system and HPV, how can I get antivirals like Valtrex, which is valacyclovir? Why do doctors not support these suggestions? That's a great question, Layla. Now, the answer is we appropriately deploy antivirals for herpetic infections, and they can be effective. You've got to be very careful at measuring liver function because that can be damaged by long-term use of valacyclovir. But interesting enough, valacyclovir does have a provenance in the CFS community of helping people who've had long-term chronic fatigue. And up until now, people haven't known why, but I strongly suspect you're right, that actually there's a herpetic virus burden sitting in the nervous system somewhere, and that actually giving you a decent course of valacyclovir and then testing the response, we may well find that you have a chance of improving. So, Dr. Finlay, we do work with these sort of things, albeit they may be off the typical license, so it's on a named patient basis. When will Novavax be available in the UK again, Andrew? It was pulled last year before we had a chance to really give it to people.
Yes. So they're talking about it being available in the autumn as part of a seasonal campaign like the flu COVID mixed. I don't quite understand the logic there, because COVID is not seasonal, and there's been a COVID wave every 3 months or so. My hope is that Novavax Sanofi will make it in the autumn, and then at that point it'll be freely available in the UK, hopefully. And then and it wasn't very expensive. When I took it, it was about £90 or something. So a triple shot of that compared to 1 shot of the antibody at £4,000 or something is advantageous if it works and you're not hyperimmune and you're not worried about vaccine injury.
Okay. So before we answer another question, I think we should ask the final poll question, which is, if you are eligible, would you consider getting a monoclonal antibody? And currently that's going to be Sipavibart delivered by our clinic in London. So let's see if people feel that actually Sipavibart, if their test demonstrated them were eligible, would you choose to go for that option as a monoclonal? Okay, so finger on the buttons. Let's see what the results are. And okay, interesting. So quite a strong response, actually, stronger than the people who wanted to get the test. So 75% of the audience, and bearing in mind it's a highly patient-heavy audience, that's quite a lot of patients, would like to try to consider monoclonal antibody treatment for their presentation if it was appropriate. I hope we've explained why it might not be appropriate in some people. So if you do need to book a test, Ellie will be putting up the link for that. And obviously you can contact Dr. Finlay at the end of the chat here, and we can organise a test and consultation to find out what your variants are that you're holding on to, and then organise for you to join our list for monoclonal antibody therapy, which will be happening hopefully very shortly in London. Someone's asked, where are the paper links? Thank you, Robert Barr. We will be sharing those when we've published, Andrew.
Yeah.
And so hopefully we'll have some links there. Question here about, do we work with people in the US? Well, unfortunately, Dr. Finlay's does not cover the US or Canada because of the prohibitive cost of medical legal fees. So unfortunately, we don't. But if you do come to the UK, we can treat you in the UK.
We have been collecting samples from the US for testing.
Exactly.
We are looking for collaborator clinics. So the first 52 patients were tested, and I'll be talking about that in a webinar tomorrow night. But we are looking for the collaborators in the UK. It's in the US, sorry.
Excellent. Question here is, if you give someone the vaccine, do they face a risk of becoming hyperimmune? And if so, can this be reversed? So if you vaccinate someone, Andrew, who doesn't have a hyperimmune spectrum, could they become hyperimmune?
The risk of hyperimmunity from protein vaccination is quite low because the protein will be cleared by other proteases in your body over time. So it doesn't remain a continuous threat. I think hyperimmunity comes from a continuous threat associated with an autoimmune problem. So I think it's unlikely that the protein vaccine will trigger a hyperimmune response.
Okay. Okay, good. And lots of people asking about availability of the Attomarker around the world. Andrew, so it's available in the US. Is it available in Canada and Australia?
So in Canada, we can ship it down to the distribution lab in America and bring it over with the next wave of tests. In Australia, we'd have to bring it back, preferably in a group, so that if there were, let's say, 30 patients were interested, the expensive bit is the cold chain shipping. But if we could persuade a clinic in Australia to collect the samples, then we could bring them back in one batch and then run it. But certainly the tasso can be sent out and we could organise logistics. If they're interested, please contact our customer care email and we'll chase that up.
Okay, fantastic. Now, another really good question from Claire Stone. Really sorry to hear that your brother's been bedbound with long COVID for 2 years. He's young, he's only 34 years old. And before this, he was young, fit and healthy. What would be a step-by-step approach of actions to take to support his recovery? And Claire, this was me when I got long COVID. I was in bed, having been very fit and active before that, albeit I was 40 at the time, not 34. And I think the approach is quite complicated. First of all, we need to understand what the presentation is and what the likely symptoms are pointing at, his previous history, and then also looking at things like the gut biome, which can be harmed by acute COVID or by immune dysfunction. Typically looking at his other risks of co-infections, so is there a risk of bacterial or viral co-infection, and looking for ways to optimize his nutrition, his central nervous system and his peripheral nervous system and autonomic nervous system function to help down-regulate any stress his body might be under, and then looking at more targeted interventions. So maybe it is antivirals, maybe it's antibacterial, maybe it is anti-COVID after some testing. So now that's a very brief overview of what might take many months. And as Andrew said, when we've been unwell for some time, we don't expect people to suddenly recover. It's quite dramatic when they do. But most of the time, the body needs to heal once you've removed the offending pathogen. It takes time for the body to reset itself, especially the brain, having been suffering from neuroinflammation and infestation of viruses. So it can be a slow road, but I do wish you well, Claire. And Dr. Finlay is more than happy to have a chat with anyone to see if we can add value or to help in your case. There's another question here about contraindication for treatments with someone who has liver issues or primary biliary cirrhosis. From my point of view as a clinician, I want to be very careful not to do any harm. First, do no harm is our oath. And so we want to make sure that we were confident that the liver was unloaded before we did any treatment. Certainly antivirals might be quite risky for someone who has previous liver issues. We might need to use a lower dose or avoid antivirals all the time. And there may be some herbal medicines that actually are slightly less aggressive for the liver that might be more of an option. What about MABs and liver function, Andrew? Are we worried about clearance from the liver at all?
We are, and I think it would be clinical judgment. You need to look at the liver function tests and find out what is known. It is cleared through the liver. It is, if the liver is not working well, it would result in a much longer, potentially longer half-life. So I would look more carefully at the pharmacokinetics. How long is it going to last in the body? We'd probably test a bit more frequently between the mAbs. But I think it makes the point that you have to turn my science into medicine. And at some point you might just say, no, this patient, the liver function is not sufficient to allow the mAb.
Okay, very good point. Rosanna Field, you've asked, can this be used in teenagers? My daughter is 15. I believe Sotrovimab has a license for age 12 and over, or 40 kilos and upwards. So if your daughter is 40 kilos and upwards, and certainly is over 12, then that might be a suitable indication. Question about stellate ganglion blocks. What is the thought about stellate ganglion blocks for long COVID? So essentially, this seems to be quite useful in switching off some of the dysautonomia that people are suffering, but it doesn't seem to be a long-lived thing, and it can make some people feel very unwell immediately after the procedure or during the procedure. So it's quite interventional. Essentially, you're trying to switch off some of the ganglia or the nerve bundles that are responsible for dysautonomia. I think it can be useful in some people who are severely affected by dysautonomia, but I would rather switch off that by other means first and try that as a last resort, because it's quite an intervention and may have other possible side effects as well. What about nicotine patches in long COVID? We've seen people actually experience quite a lot of benefit from nicotine patches, and they're relatively safe, although you have to be careful about dependency. We're not wanting people to start, getting addicted to nicotine, which is addictive. But to avoid that, we would put the patches on, initially for a couple of hours a day, see if that tolerates, increase that up to, let's say, 12 hours a day, taking it off overnight and having a gap at the weekend to avoid dependency. But the acetylcholine release that happens with nicotine may be beneficial for brain function and for mood and nerve signaling, and bumping COVID spike protein off nicotine receptors can be useful. So it's definitely worth a considered try under medical advice, and we do find some benefit from that. Lastly, someone's asked how I'm doing with my own long COVID. Ben Sheehan, thank you. I'm back to running in the woods. I'm running a national company that's growing and treating people throughout the world. So Ben, thank you. Ironically, what I found was my COVID kicked off an undiagnosed latent Lyme disease that has now been treated, and I'm now fully recovered, having had full treatment for Lyme disease and treated myself for long COVID. So I'm actually fully better. I'm aware that time is marching on, and some of us may be suffering from brain fog if you're patients. So I just want to thank you for joining us today. And I think what we could do is of course, thank you all for coming. Andrew, I want to thank you for coming. And as a sort of a final thing, we have more questions to answer. So we'll probably do another one of these going forwards, probably after the summer when we had a chance to treat more people with Sotrovimab. So if you'd like to book on to get an Attomarker test and consultation, Ellie, you've kindly put up the link. So see the webinar chat link, get your test done. Get your results. That takes a couple of weeks to come through, so bear with us, and then we'll book your consultation with our clinicians to go through the significance of those results. So I think now there's still more questions coming through, Andrew, but I think we probably better wind up there because we're going to burn everyone's brains out. So Andrew, thank you so much for your input today. It's fascinating talking to a professor who understands this, because not many people around the world I've spoken to, and I've spoken to a lot, actually understand this subject. So I really appreciate your expertise in this.
Yeah, I confess to only learn a bit now, and as the data numbers increase, we're learning more every day. But we have some insight, and I think making the science work with the medicine, I think that's an interesting way forwards.
Brilliant. Well, thank you for joining us this evening, and we really hope that if you're a patient, you can begin your journey to recovery with more information, and hopefully be able to get the right treatment for you that will make the difference. So thank you for joining us, and we look forward to seeing you at our next webinar.